Hello, everyone, and welcome back. I'm Joe Chappelle, and you're listening to episode 35 of the OBGYN podcast. This is the monthly checkup for June 2018. And with me today is the always wonderful and now chief resident, Sara Kim. Welcome, Sara.
Glad to be back. It's been a while. How's everyone?
And I'm also very excited today to have Dr. Jillian Kurtz here. She recently did a wonderful episode on the fertility preservation and also is a newly graduated from her residency program. So welcome, Jillian, and congratulations.
Thank you. Hi, everybody.
So before we get started today, I want to do a little follow-up from the last monthly checkup. In that episode, Dr. Ballas and I were talking about the declining U.S. birth rate, and in particular, the teen birth rate, which had a dramatic decrease from its high around 1990. Now, one of our listeners asked about the termination rate during that time to see, is there any decline in that as well, or does the decline have to do with increased terminations, or what was the correlation there? So I did pull a little bit of data. Unfortunately, the last data I have is really from 2010, 2011, so it's not current, but it's interesting. And in fact, the teen termination rate has also been declining since 1989, 1990. In 1990, there were 116 pregnancies per 1,000 women aged 15 to 19. And in that year, about 40% of those pregnancies ended in a termination, which, if you do the math, means that about 4% of women in that age group were having an abortion every year, which is kind of a staggering number. Well, in 2011, the pregnancy rate had dropped to 60 per 1,000. It's even lower in this recent data that Jerry and I went through last month. And about 15% of those ended in termination. So, in fact, both the pregnancy rate and the termination rate have been declining significantly for the last 20 years. So, why is the pregnancy rate going down? Well, it's not from increased termination, but really nobody knows. Maybe it's better sex education, maybe it's better access to contraception, or maybe it's just changing attitudes towards sex in that age group, which has also been reported. I even heard one source report that they thought it had to do with the MTV program 16 and Pregnant, because that came out around the same time the birth rate started dropping a lot in the late 90s. So who really knows what it is? We're probably never going to know because it's hard to measure those things at a societal level. But what I want to kind of urge people is don't become complacent about it. We still have a lot to do when it comes to what we can do, which is education and access for these women to get contraception. And a lot of times teens actually have the hardest time getting those things anyway. So we need to keep doing what we're doing and hope that it all kind of goes together and that rate starts to decline some more.
Yeah, I think that's really interesting. I think that ACOG is doing a good job really promoting LARC usage in adolescents. They have that committee opinion about the appropriate use of LARCs in the adolescent population. So hopefully some of this is, like you said, better access and availability of contraception for the teen population.
There were definitely, one of the things people were talking about is not just better access, but also better contraception. I think that goes into what you were saying. LARCs definitely have a much better failure rate just because, you don't have to take it every day and they're hard to forget. So I think you're probably right. That does play into it. Now, I'll be honest, in my patient population, I don't have a lot of 15 to 19-year-olds who come to see me. So I don't feel that as far as putting LARCs in, but my colleagues who do pediatric adolescent gynecology are definitely putting in a lot more of these Skyla or the generic Skylas, and I think that is definitely a step in the right direction.
Yeah, a lot of that population is now coming more and more and asking for them too. So, I see a lot of patients, not too much, but in that we have family planning clinic where they come in and say, I've heard about this IUD, my friends have this Skyla, I want to hear more about it. And even some of the parents or like the mothers are bringing their daughters to it. So I think definitely there's more access and there's some education, and there's also people who like it enough that they are actually advertising it to their friends. So I think hopefully we'll continue to do a good job about, contraceptive counseling and education.
All right. Well, so that was a follow-up from last week. I hope people listened long enough into that episode, because I know it was long, to get to the teen pregnancy part. But so we followed up on that and we answered a question. So today we have probably 2, maybe 3 if we're lucky. I think very interesting, thought-provoking articles. The first two that we're going to go through are very, very technical, and they're dense. And I think all three of us are not experts in these fields, so please do not take what we say about the specifics of these papers and take them anywhere and do anything important with them. But I do think they raise important questions for us as clinicians about how we incorporate new technology and new findings in our daily practice. And so I thought they were at least interesting to talk about. So the first one is a paper that was published in Science in 2018. It was by a group at Stanford, and the title was Non-Invasive Blood Tests for Fetal Development, Predict Gestational Age, and Preterm Delivery. So what this group did is actually, it's stealing a little bit of thunder from the next aneuploidy episode, which is talking about cell-free DNA, because this technology comes from that. But they were actually looking at cell-free RNA from genes from the placenta, the maternal immune system, and the fetal liver. And they had previously shown that the RNA from especially the placenta and the fetal liver increase as the pregnancy continues and then return to zero after delivery, so they're reasonably sure that these are really from the baby. And they also found that the placenta and the fetal RNA were correlated and meant that the placental RNA may be able to be used as a way to estimate fetal development, which is interesting. So they then compared their algorithm that they developed against the last menstrual period and ultrasound and found that the ultrasound and their algorithm agreed within 14 days of each other. And this is where things get a little interesting, because they argue that that makes it just as good as ultrasound and that it's cheaper and you don't have to have an experienced technician or an ultrasound machine and so on and so forth. So I'm going to stop at that part of it. The preterm delivery part is even a little more wacky. So just starting with that, I really found that this technology, I think we're just scratching the surface of what this technology is going to do. But I do like that they're looking at what the baby is expressing. And we're able to detect that in maternal serum, which is something we went through in the last aneuploidy about AFP and things like that. And then trying to use that to say, okay, well, how far developed is this fetus, which is different than gestational age. And that's not something they really put in here. And I think that, to me, may be the most interesting part, is looking at fetal development versus quote-unquote gestational age.
Yeah, I think they're trying to address an important question. We all can agree that having accurate gestational dating is important. We've all had these women come into labor and delivery triage complaining of preterm labor symptoms, no prenatal care. We do a shoddy bedside ultrasound, and she, of course, is 23 weeks, right at the cusp of viability. And we're trying to decide, okay, do we resuscitate this baby or not? And if we could have an extra tool to help us more accurately date her pregnancy, I think it really could be a great thing.
And kind of going off of that and kind of what Dr. Chappelle was saying, that it not only will give a gestational age, but they're using this as a potential marker of development, and that could potentially give information about the maturity of the fetus as well. So it could be approximately 23 weeks periviable, but maybe it's almost close to like a 24-week, or they may be measuring like 23 weeks. So if we could use this as a marker to kind of assess the actual development of the fetus, it might give us a little bit. It could be another tool, I agree, so that in terms of that dilemma that we come across with people who never had any prenatal care.
Yeah. And then, let's make a hypothetical future where this test exists, it's commercial, it is reasonably fast, and it's reasonably cheap, which, by the way, none of those things were addressed in this paper. I will get into a little bit of the specifics about how many people they had in it and the limitations in the second part, but spoiler alert, it wasn't a very big study, right? So this is just a hint that it may work. But let's say for a minute that it works, and you have this woman who comes in who is, maybe 24 weeks, or let's say we even have good dating, and she is 23 and 3. And you do an estimated fetal weight, it comes about, 490, 500. And so we do this test and it says, oh, well, this baby is as mature as a 25-weeker. Are we going to use that to determine if we resuscitate or if we do a C-section? That's where I feel like this technology gets anytime we add new technology, it gets a little tricky. We see this all the time. Look at FFN, being used to give steroids. Remember, I don't know, you guys may not be old enough, but It wasn't that long ago that people were giving steroids on a weekly basis for people with a positive FFN, right? And so, we get this new technology and we start doing things that the inventors never had in mind for it to do. And sometimes it leads us into trouble. So I don't know. I have reservations. I also, going back to their 14 days, so it was within 14 days of the ultrasound, which, in the second trimester, plus or minus 14 days is the accuracy of the ultrasound. So I'm not really sure that this makes this really that accurate. Like 2 weeks is a big difference.
Yes. Yeah, it is. Not only about accuracy, and I think at the end of the day, they probably want to argue that it might be a better way of estimating the date, and I'm not sure, at least from the study, that we could necessarily make that conclusion. But it is definitely interesting to see them measuring this and how they went from like cell-free DNA to measuring cell-free RNA to get the estimated, I guess, gestational development of the fetus.
Yeah. So I'll read this one little line here before we move on to the preterm delivery part. But so they said, our results are thus comparable to ultrasound measurements, can be performed throughout pregnancy, and do not require physiologic knowledge such as the woman's last menstrual period. Well, with ultrasound, you guys know, right? So during the first trimester, if you have an LMP and an ultrasound that correlates, well, then we go by the LMP. That's good dating. If it's in the second trimester, then ultrasound alone is plus or minus 14 days, right? So what this is saying is that this is also plus or minus 14 days, but you're never using the LMP. So what you're really getting here is just as good as kind of bad dating with an ultrasound. So again, it's really only useful, and I think that the case that Jillian was saying, where they come in with no prenatal care, and now we want to come up with some kind of assessment, and we don't want to trust our crappy bedside ultrasound at 2 o'clock in the morning in triage, probably done by a new intern in July, right? So I think that may take out some of the subjectiveness of it, but it definitely, I think they're overselling it a little bit when it comes to how good it is at dating or how useful it is at dating.
I thought they were also probably overselling the cost effectiveness of it, because there is an initial investment with an ultrasound machine, but one machine and 10,000 scans later, what's the actual cost of that one scan is really not that much. What is the lab going to charge for doing these PCR tests again and again?
Right. I mean, well, if we can judge by the cell-free DNA tests that are out there, it's not going to be cheap.
Right.
So, I can tell you that from our patient experience in prior practice over the years, now pretty much is covered by insurance, but 4 or 5 years ago, it wasn't really universally. And we had women come with a very large, 4-digit bill from their cell-free DNA testing, and they were a little upset. So maybe it's a little cheaper now, but it's certainly not cheap. And I can't imagine this is that cheap, because now you're not even just doing trisomy 21, 18, 13, and maybe sex. You're doing like 8 or 12 or 18 different cell-free RNAs. So anyway, I agree with you, Jillian. So then the second thing they did, and I thought this was actually very clever, but they looked at these cell-free RNA markers they had, and they found that they predictably changed close to delivery. And so their first cohort was all term women who delivered at term from Denmark. And as we all know, Scandinavia has the healthiest women in the world with the best records. But so all these women who had healthy pregnancies, they delivered at term, and they said, we could actually identify a few days ahead of time when these women were going to deliver. And that was interesting. So I said, okay, well, let's see what this does in preterm women. And here's where you can tell that this was not done by clinicians, because they had recruited 2 other cohorts, which they called one cohort, who were either women who had preterm contractions or women who had a history of preterm deliveries. And as the 3 of us know, those are 2 completely different populations with really different risks for preterm delivery. So, and in one group, the history of preterm delivery, they all got progesterone. And still 3 of the women who were only preterm contractions also got progesterone, which, we'd have to discuss their guidelines in Pennsylvania where these women were. That's a little odd. So anyway, they used these women, they ran their model, and they found that there was no correlation. All the stuff they used for term didn't work for preterm. And then they read this. I'm not even going to go through it. But they looked at all these different genes, and they found a set of genes that worked, and there were 7 of them. And they found what they considered to be a good test with good positive predictive value, low false positives for predicting preterm labor. But I'm not interested in that. What I'm interested in is that they found different genes in the preterm and the term women, that maybe there are actually different mechanisms for labor initiation in these two populations. And that's what I found very, very interesting about this paper.
I agree. I like this part because anytime we're looking at a study, we want to see, is there some sort of information I can take from this test to create an intervention and have a positive outcome as a result of that. So if we could detect these women early on and get them started on progesterone or something like that, see that they're high risk, then we could potentially change outcomes.
Yeah, so they actually, looking at their data, they had a false positive rate of 5% and a positive predictive value of 80% with their new test that they did, comparing that to FFN, which is a 21% positive predictive value. Actually, that seems a little low for FFN. I thought it was closer to 50%. But in any case, much better. 80% is much better than even 50% or 21%. So they're really quoting that. And again, do I really need another test for preterm labor? I don't know. We don't have a good one now, so maybe we do. But of course, these women were 2 different populations. Like I said, they were both very small. There were 15 in one group and 27 in the other. So again, I don't think we're going to be having a new test approved by the FDA next week based on this data. But again, going back to what I said, I think that you look at the genes that they found, and now we have avenues of research to say, what about these genes is correlated to preterm labor? Can we then now go start looking at these pathways and say, are there enzymes or other things that are triggering preterm labor where maybe there's an actual intervention at a RNA level, a protein level, that we can use to stop preterm labor? Because as we all know, we have no way of really stopping preterm labor. We can slow it down maybe for a couple days, and that's about it. But if we can actually determine what the triggering and inciting event is at a proteomic level, maybe we can have a chance at designing something good.
Mm-hmm. Yeah, that's what I found really interesting about this paper too, in the sense that I felt identifying those genes and those proteins is a way to kind of capture and maybe identify these high-risk patients earlier on than the tools that we have now. I know there's no way to really predict patients who will actually go in, their risk factors, but I felt that there's some promise of maybe we can predict patients who are at high risk because they have these proteins present of actually going into preterm labor. And I agree with you in the sense, once we identify those patients, if we know those pathways, can we actually stop that from happening? Because obviously, like you said, we don't really have any way to prevent it. Once they go into preterm labor, they're in preterm labor, and there's really no way to stop it. So I think there's promising aspect to the research of how do we identify these patients using these genetic markers really early on, and once we've identified them, how do we actually prevent them to going into preterm labor?
The paper didn't specify at what gestational age. They said 2 months before they delivered, they discovered, or they were able to detect the difference, but They didn't say at what gestational age that was, which I thought would have been good information to have.
Yeah, again, I don't think this was done by clinicians, and obviously was published in Science, which I'm not going to say anything bad about Science or the journal because it's a lot more prestigious than any of our journals, but it's certainly not a clinical journal. And again, even if you have a 99% positive predictive value of predicting preterm delivery is going to happen in the next 2 months, well, that's not very clinically useful, is it? Right, and I think that's what you were getting at there. And so they may be very good at doing it, but not in a way that clinically makes sense for us. So, but I think there's promise, and more than that, I think that this avenue of research with cell-free RNA and proteomics, I think maybe the next step in how we start to understand pregnancy and labor and other things. So I'm very excited to see where this technique leads. I mean, I have talked in a couple of my other different podcasts about revolutionary technology like the radioimmunoassay and what that did for medical research starting in the 1960s. And I think that this cell-free RNA for pregnancy may be one of those technologies for us. And so I personally can't wait to see what happens in the next 20 years with it. All right, anybody have any other thoughts or statements or anything they want to talk about proteomics?
No, interesting article though.
Yeah,
Okay.
definitely.
All right, so I'll move on to the other paper, which we also are not experts to talk about, but we're going to do it anyway. That doesn't stop us here at the OBGYN podcast. So the next one is a paper from Nature Medicine. We're hitting the big ones today, Nature and Science. We can't go any better than that. This is from Book Tata from a couple of different countries, France, Finland, and Italy. And it was published, like I said, in Nature Medicine in, I think it was this last month, 2018. So, I had done a couple episodes about PCOS a little while ago, and this kind of popped out at me. And the title of the paper is Elevated Prenatal Anti-Müllerian Hormone, or AMH, Reprograms the Fetus and Induces Polycystic Ovarian Syndrome in Adulthood. Now, that title I think is completely incorrect, but we'll get into why I think it's incorrect in a minute. But what they really did is one of the things we know about PCOS is that these women, especially the lean women, so again, to go back to my previous episode, there's probably two phenotypes. There is the skinny woman with PCOS, and then there's the obese woman with PCOS, and they're probably different women, different reasons they have PCOS, different pathways. So in this, they really looked at lean women with PCOS, and we know that these women have elevated AMH. And so they looked at these women when they were pregnant, because normal pregnant women have low AMH, and they looked at pregnant women with and without PCOS, and they found that, lo and behold, and kind of unsurprisingly, these lean women with PCOS still had elevated AMH during their pregnancy. And so they wanted to see what effect could that AMH have on their fetus. Now, they didn't do this study in humans, right? The next part of this. All they did was find this finding, and everything else they did in mice, which is fine, which is why I don't know that the paper where it says it reprograms the fetus and induces PCOS in adulthood, I mean, if they said in mice, that might be a little more accurate. I think this is a little misleading. But anyway, so then they did this studies in mice where they give mice AMH. It's a complicated study. There's a whole different arms, and they use AMH and they use GnRH. But really what they found was that the AMH actually acted on the GnRH neurons and changed the way they secreted GnRH, and plus a few other things, but that these effects lasted after the mice were born into the neonatal period. So it was reprogramming the brain to make that fetus have PCOS. And I thought that was interesting because, again, this is another one. We don't know why women have PCOS. We have identified the syndrome. We know what it looks like. We're working on some ways to treat it. But because we don't know where it comes from, we really can't design any tests or treatment. But here we are, and there's actually a fundamental change in these mice' brain by being exposed to AMH. And I thought that was fascinating to me. I don't know how we can really use that in a clinical setting, is that maybe fMRI or something like that. But I think that even having an idea now about where the pathology in these women resides starts to point us in a direction for further clinical research.
Yeah, I mean, we think of an elevated AMH and PCOS as sort of a reflection of the pathophysiology of the disease. She has lots of follicles, therefore lots of granulosa cells and lots of AMH. This is the first time that I've seen a group suggest that the AMH itself has a role in actually, activating these GnRH neurons and propagating the disease itself. So I thought this was super interesting. It's like, what came first, the chicken or the egg?
I was just going to say that. Took the words out of my mouth. Now, I have some questions about their conclusions in this paper, because they then say that they think that maybe this is the reason why women have PCOS to begin with. But as we all know, although women with PCOS, it can run in families, it doesn't always run in families. There are women who come to us who, their mother, their sisters, their aunts, everyone else is fine, and they're the only ones who have PCOS. So I'm not really sure that this is the be-all, end-all of what causes PCOS. But it's an interesting avenue to explore. One of the hard things with PCOS is that it is a syndrome, right? And just like in the last paper, when they included different kinds of women who are at risk for preterm delivery together, you start to muddy the picture. Like, what are the actual mechanisms that may be different in those two populations? And we have that with PCOS, is that we don't even know what the populations are. We just know that, all these women kind of look the same, and so we include them all in our studies because we don't know who to exclude. But maybe this group of women can be identified and said, okay, well, at least you set are different, and we're going to study you differently and exclude you from this broader characterization of PCOS, and maybe there's something there. So I think maybe we're starting to suss out a little bit of the differences, which is exciting to me as someone who cares about PCOS.
Yeah, I think that's what the takeaway that I got from this very complex paper was that I think they focus on the one specific phenotype of the lean PCOS phenotype, and they're trying to define and characterize that more. And I think that's kind of shows how complex, like you said, PCOS is a syndrome. It's kind of a conglomerate of symptoms and signs. It's not just defined by one mechanism, and I think this kind of sheds a little bit more light into the lean PCOS phenotype and maybe what is the pathophysiology behind it, and what is the role of AMH, in utero and ex utero, and what are the long-term implications. I think gives a small glimpse of that, of how, because it is a complex, it's multifactorial. I agree that the broad generalized statements that the paper makes, I think it tries to simplify what they're actually doing, try to make it more generalizable, but I think it does definitely shed some light into the complexity of PCOS and particularly focus on this one specific phenotype, because they do mention that it wasn't found really in the obese phenotype, and they kind of stopped, and focus on the lean phenotype mostly. So I think that definitely that was a takeaway message that I got from this paper mostly.
Yeah, I think that all of us would agree that the most common phenotype is the obese woman with irregular periods and elevated testosterone. And these women, these lean PCOS, are much rarer. But again, if we can separate them out and say why they have something, maybe that leads us into why the women with obesity have their PCOS and symptoms. So, maybe again, it just sheds, by figuring this out, it can help us figure out the other side of it. I don't know, but at least it's forward progress. Because for years now, for decades, all we've really been doing is outlining the issue, and we haven't really been filling in the details. So I think this is a good first step, hopefully, at starting to fill in some of the details in the middle of the pie here.
Oh, I was just going to say, I would have liked to see the IRB for this study. I feel like there was no specific aim. They started with one thing, and then they kept experimenting, and at the end I just couldn't believe how much they actually accomplished and were able to write up in one paper.
Fair. Well, I think when you're dealing with mice, it's a little easier, maybe. I don't know. Certainly in our IRB, if it was humans, we'd be 10 years from now still trying to get approval for the first part of it. Every year about now is when our second years start trying to get their IRBs in, so that we can start their projects, collecting data and whatnot. In our residency program, the ending of third year, you present, which is what Sara just did a couple weeks ago. But getting through the IRB every year is it's exhausting. And I try to help all of the residents get through the IRB. So usually by the end of the summer, I'm exhausted. I don't want to hear the words I, R, or B together in that order.
One thing I did like about this paper is at the very end, they sort of allude how we could use this information to guide treatment, how you could use a GnRH agonist to sort of restore the normal hypothalamic pituitary axis, which I thought was a great idea for treatment. As of, for now, what we do to induce ovulation doesn't actually restore the axis. But if we could, bring it back to a normal hormonal milieu, it's an interesting idea.
Yeah, that was what I was about to say, is that there's promise in this fact that they could reverse the phenotype almost, that by adding the GnRH, it's not just, let me just cover it, but the mice that actually had that phenotype, they gave GnRH antagonists, GnRH, and they were able to almost reverse it completely. So if you identify these patients early on, because this patient was exposed to AMH in utero, let's give GnRH early on, maybe the whole phenotype could be reversed from the get-go, and they will never have that, and everything, the hypothalamic axis will be restored back to its norm, and the hormonal balance will be achieved. And I think that was really interesting and a potential for further research down the road.
Yeah, I mean, the way they gave it was they gave intermittent delivery of a very low dose of GnRH. And we know the way GnRH works in the human brain, right? It's pulsatile. You give GnRH agonist, and you give it continuously, and you shut everything down. So here they're kind of mimicking the pulsatile nature a little bit, and with the low enough dose that it's not going to outcompete everything else. So, that is definitely a different way of doing things than the way we administer GnRH. Now, right now, we don't really have an easy way of giving pulsatile. I mean, it's maybe a pump. You could do like a GnRH pump, maybe, like an insulin pump. Maybe you could do it that way. Because most of ours are just, depot or one-time injections, right? So we don't really have a way of even doing something analogous to what they did. But certainly, again, it's an interesting avenue to start exploring. And this is where, what we're going to do in 10 years comes from, right? It started in this paper in 30 mice in France, Finland, and Italy, right? And 10 years from now, we'll be giving everyone GnRH pumps that has PCOS, right? So we could say that we saw it first, right?
Right.
All right. Anyone have any other further thoughts about the AMH or the implications of that study?
No, super interesting articles, but I felt like they brought out a lot more questions than they answered for me. Just made me have to think a lot more about what still needs to be understood about this topic.
Fair enough. And I think, to me, these kind of papers are what, not these particular papers, but these kinds of papers where I come out with a lot more questions are the things that start me down a path that may end in a research question. Right? You read something else that maybe if it's not related to what you do, you say, oh, that's interesting. And the way they did that, now how does that work? How would that work with this? And then you go look and no one's done that. Can I do that? And a lot of times the answer is no. I'm not doing proteomics. I don't do it. I don't have a background, right? And I don't have a lab. But sometimes you read other papers and you say, oh, that's interesting. I think I could try that. So I like to be challenged like this in a way that brings out my intellectual curiosity. It reminds me why I like to not just be a doctor, but be a scientist, right? So we're all scientists, I hope, right? So these papers bring that out in us, which is good.
Yeah, definitely. The papers made me think about these topics in a new light, in an avenue I never thought of. The cell-free RNA is completely new, and PCOS, I didn't even think about knowing how pathophysiology starting in utero. That was something that I wouldn't have even thought about, even though I knew there was a potential component to it. But it does definitely, tickle some questions. And I think this is why there's one of the big in science right now is translational research. And I think this is the beginning of, here's some bench work that has some clinical relevance. How do we translate that into something that clinicians can use and that's actually relevant to the patient population that we have? So I think these are very interesting papers, that really gives good questions generally.
Right. Well, I want to thank you both for reading these complex papers and trying to digest them so that we could talk about them today. That's a lot of work at the end of the day. I think I'm going to skip the last one we had planned for today. We'll save that for next month because I think it'll dovetail well in with the second episode of aneuploidy. But for tonight, then, I want to thank Jillian for joining us for the first time. It was so nice to have you, and I can't wait to have you on future episodes.
Thank you.
Yeah, it's nice to meet you.
Yeah.
Congratulations on finishing your residency, and good luck with your new attending job. I know you're going to do fine. And Sara, congratulations on being a chief resident. Thank you for joining us.
Woohoo. Always happy to be here.
And Sara, actually, I don't know how much Sara's going to be with us this summer because she's actually applying for oncology fellowships. So we'll wish her the best with that and hope that she can sneak in a few recording episodes in between interviews.
Yes, I hope to join, but, I'll be a little bit busy, a little nervous. Wish me luck.
Oh, good luck,
You'll be
Sara.
fine, too.
Thank you.
So thank you, everyone. Thank you, everyone, for listening. And we'll be back hopefully next week with a Journal Club episode on a gynecology topic. So that should be interesting. So until then, thank you, everyone. Have a good night.
Good night.
Night.